My name is Dr. Daniel Kantor. I'm the president of the Florida Society of Neurology and the medical director of Neuralgia, an organization dedicated to patient-centered care, research, and education. I've been tasked with the job of updating you on the exciting world of MS. It's exciting because prior to 1993, we had no medications FDA approved. And now, as we'll see, we have an asymptotic increase. Another title for my talk, though, is actually the vital role of case managers. And this is becoming increasingly apparent. So multiple sclerosis, I don't like using stigmatizing language such as chronic, but it is a chronic lifetime. Not lifelong, that makes life sound long and arduous. Lifetime, like showtime. You turn off the TV and it's still going on in the background. And much like the cable station by that name, you still have to pay your cable bills even when you're not paying attention to it. So in MS, people are not always having neurologic symptoms, yet they have to remain on treatment. I have been reminded that there is a cable station called Lifetime, but I'm a man, I've never watched it. It affects the central nervous system, so not the peripheral nervous system. So not when you think about diabetic neuropathy and lower back pain. It affects most commonly the spinal cord, then the optic nerve, then the brainstem. And that will be with vertigo, with the spins, and double vision. It involves not just loss of white matter, but also axonal loss, so actual neuron damage. And as we heard, it's in genetically susceptible individuals with some sort of environmental trigger. So when we look at this, there's activated T cells, these immune cells that normally fight off viruses, bacteria, and fungi, get activated, they cross the blood-brain barrier. Then what happens is they launch an attack on the myelin and the nerve fibers, and they wreak the havoc of multiple sclerosis. We talk about separate types of MS, relapsing remitting, where people get better and then they get worse, get better and then they get worse. Secondary progressive, where that may happen, but then the person continues to progress even in between relapses. And primary progressive, where the person says, what do you mean better? It's never gotten better for me, it's just been continually declining. There is a small subset called progressive relapsing MS, but I actually think it's a subset of secondary progressive MS, and I think we just forgot the first relapse. So as physicians, we care about the relapse. We can see that the person has lost a lot of vision in their eye. Not completely blind, but has lost a lot of vision. And that's actually what happened with Jack Osborne when he had optic neuritis. But for the patient, they often care about what happens in between the relapses. They want to know what their day-to-day functioning is. So as I said, there are symptoms and they can be very varied. Anything that affects the central nervous system, so the brain, optic nerves, and spinal cord, cervical and thoracic spinal cord. People start having problems well before we know. People actually have MRI changes, and there's something called radiographically isolated syndrome, where people have MRI changes with no symptoms yet. And now we're even talking about whether we should treat that. But we do have trials now on most of our medicines looking at clinically isolated syndrome. So when the person had their first attack of MS, we try not to wait. We don't wait for someone to decline. We try to treat as early as possible, before you see that continued progression and before you see that accumulation of disability. I like to talk about the triple threat in treating multiple sclerosis. There's a support group, and in MS, if anybody works with MS patients, you know that there's a rich community of support groups. They're called the MS Katirs, and they're in Deltona, Florida. They let me use their name. And yes, that is a sword. This is my depiction of a sword. So there's disease-modifying agents, symptomatic treatment does not have to be a medication, and then acute exacerbation treatment. So when we're looking at the FDA-approved medications, I'm trying to give you guys really this 30,000 feet view, and come in and talk about certain topics. This is what is currently FDA-approved for the treatment of multiple sclerosis. And as you'll see at the bottom, we've gone from the beta interferons and glatiramer acetate from the injections to natalizumab, which is an intravenous medication every 28 days, and then fingolimod, the first and only currently FDA-approved oral medication. Mitoxantrone is used a lot less. It's a chemotherapeutic agent, with a maximum lifetime of about 2 years, and it can cause congestive heart failure, and 1 in 150 people develop leukemia. So we've moved away from it. But when we look at our older trials, the problem is a lot of people focus on the older trials and say these drugs aren't that effective. What you see, though, is as we've moved to newer ways of doing trials, we've seen a reduction in the relapses even prior to being on treatment, and even on the same treatments. Some of these trials are on the same treatments as what you see on the other side, on the left-hand side. And we can see now we even have medications. This one is for a medicine called IV alemtuzumab. And what happens is we see a complete reduction in the number of relapses. We really see this sharp decrease. We mentioned the oral medication. We're seeing clinical trials now that compare not just to placebo, which is very hard to enroll in the United States, but also compared to other medicines. This shows about a 50% reduction in relapses, not compared to placebo, but compared to interferon beta 1A intramuscular once a week, trade name tizavans. So what is the role of the case manager in the past? For the injectables, we need your help obtaining medication approval, coordinating the injection training, laboratory monitoring, and follow-up on injection side effects. Now, because these medications are high-priced, and they are high-priced, for employer-paid health plans, the #1 cost for pharmaceuticals is all other autoimmune disease, then multiple sclerosis alone, and then neoplasm, cancer. Because people with MS have overall an almost normal lifespan. And so they're going to live, and some of the medicines now cost $48,500 per year. So I would say if somebody's going to be living for 30 years, you multiply that by at least 50,000, you're going to get much higher than 2 million mark per year just on medications alone. Luckily, the companies, because they cost so much, they have put a lot of time, and they have some of their own case managers and nurses that work with injection training. Neuralgia, also called IV Tysabri, has a REMS program. It was the first medication in multiple sclerosis to have a risk evaluation and mitigation strategy. And so we need help in obtaining the medication, in going through the touch, in coordinating laboratory monitoring, and following up on some of the special kinds of reactions. With mitoxantrone and other chemotherapies, which we use off-label, it's getting the medications, making sure they get paid for, making sure the patient has access to care. Some of my patients were told, well, if you go on an off-label medication, we not only won't cover it, we will not cover any side effect you have from that for the rest of your life. And so if a person has pneumonia 30 years down the line, that could potentially be blamed on a chemotherapy. The expanding role of case manager. When we talk about the oral medication, fingolimod just had an FDA label change, and we need help obtaining medication approval, coordinating laboratory monitoring, coordinating other types of physicians, ophthalmology, some of us use cardiology, dermatology, and sometimes even pulmonary function tests. There's a first dose administration. People have to come in for 6 hours, and that's hard to coordinate from the patient point of view, from a payment point of view, from where you're going to put them in the office point of view. Sometimes we use urgent care facilities that have been contracting with the sponsor of the medication. Now there is this need for 23-hour observation in some patients, and we're still clarifying which patient that is, and then how do we do it? If you don't work in a hospital system and you're a neurologist taking care of MS, how are you going to admit them for 23 hours? And then if it is 23 hours and it's an observation, does anybody get paid, or is the patient expected to be paid? These are issues we're dealing with on a daily basis. And then, of course, there's following up on medication side effects. We have to screen for macular edema. It's a special side effect in 0.4% of people. So a low amount, but still a side effect we're not used to in neurology. And then there are headaches and some other, but mostly well tolerated. This is the landscape of MS. We go from the medicines that are already approved to, you see cladribine was rejected by the FDA. Then you start to see the ones in yellow. We're going to get to the medicines that we're going to see hopefully in the next 12 months. And then one of them has 2 colors. That's liquidomide, because the studies weren't adequately done, and they're going to have to go back and change the dose. So it's kind of in between phase 3s and the completion of the phase 3 itself. Then there are 2 medications in green. One of them is called standard release dalfampridine, as well as Nudexta, which is a mixture of dextromethorphan and quinidine. And we'll get to this class of medicine which is not disease modifying. The medicines we're getting, you have in your booklets all the data, and this data is as current as the press releases that happened this year. Last month we saw a press release, and that's where we see our data in neurology. We see it from the American Academy of Neurology, from the big European meeting, ACTRIMS, so the European Committee on Treatment and Research in MS, and then we see it from press release. So what you can see is we have an oral medication, and actually they are saying that they're the first oral medication to have 2 phase 3 trials that shows it has an effect on relapse and disability. Now you'll notice that the lower part is less information, and that's because in press releases we get a lot less information. But we will hopefully by September see this medication as teriflunomide 14 milligrams, which some of you may be familiar with leflunomide, which is the parent compound. So there are safety issues that we're going to have to explore. This is going to be an oral daily medication, but liver function tests. There is this issue of hair thinning, and in a population that is mostly a female population, mostly of childbearing age, this as well as the pregnancy category for leflunomide, which is a pregnancy category X, and we don't know what teriflunomide will be. Of course, these become major issues for us. IV alemtuzumab. IV alemtuzumab was compared not to placebo, but to interferon beta-1a subcutaneous 3 times a week, so to rebif. And compared to that, it showed in one trial, CARAMES-2, in treatment-experienced patients, an effect on both relapse and disability. And in CARAMES-1, which was a treatment-naive trial, it showed against relapses. In the phase 2 trials, it was 70% better than current therapy. In the phase 3s, it's 50%, but that is still a giant leap forward. Of course, safety is going to be the issue. This is a medicine given once a day for 5 days, then nothing else for the rest of the year. Then once a day for 3 days, then nothing else. Maybe ever, maybe for 2 years, for 5 years, for 10 years. The biggest problem is going to be side effects. We have other autoimmune diseases, although I do say now we can replace thyroid, but we can't replace neurons. So 30% of people are going to have thyroid dysfunction. But some people are going to have even more dangerous side effects, such as idiopathic thrombocytopenic purpura, so an immune attack on their platelets, and that can lead to bleeding, and in fact, one person died in the clinical trials. But they died because they didn't seek care. And that's one of the things we need case managers for greatly, because one of our problems are people are going to get lost to follow. They're going to feel great, and they're going to say, well, we don't need a refilling our medicines. We're done. I think we're going to need to create a community of MS survivors, similar to the model of cancer survivors, where even though you're out of it, you may at any point, the MS may come back, or you may have a side effect. So you still do need to have your laboratory monitoring. Of course, other things that are going to be an issue are going to be infections and potential for other neoplasms as well. Oral BG12, there's a lot of excitement about this medication. Twice a day, oral medication, mostly safe, mostly tolerable, and looks very effective in 2 clinical trials. Tolerability is a little bit of an issue, and really we're going to need case managers to help and encourage compliance, because there's tachyphylaxis, but the side effects are diarrhea, and there can also be flushing. And even though that will go away possibly in 2 months, we need to make sure our patients are motivated for that first 2 months to be able to do it. So the case manager role for teriflunomide is going to be the contraception pregnancy issues. For alemtuzumab, it's going to be all the REMS programs. We're going to see REMS for everything, but it's really going to be about that. And it's going to be critical that patients don't get lost in follow-up. For BG12, besides encouraging compliance on twice-a-day medication, we're also going to have to follow up on the long-term safety data, because there is some question now about the long-term safety data. We've talked about disease-modifying agents, there's symptomatic treatment, and now we're going to talk about during a relapse. Now, during a relapse, it means that you have a new or worsening neurological symptom, and it's usually going to be longer than 24 hours, usually weeks to months, really. And we have to make sure a person's not having a pseudo-exacerbation. So a pseudo-exacerbation or attack or relapse, not exasperation, as some of our patients call it, is going to be a reversible worsening based on heat, and that's why cooling vests are so important. That's why we work with nonprofits such as the MS Foundation and the MS Association of America. And as a case manager, you get more used to the fact that those two large nonprofits are more about patient services as opposed to National MS Society, which is a lot more about fundraising for research. Everyone has their role. Our nonprofit is much more about education, especially social media education. We have active Facebook and Twitter and all the rest. So the treatment is going to be with steroids, but also not with steroids. You may see with even off-label with IVIG, plasmapheresis, and ACTH is FDA approved, but very expensive. To treat an exacerbation, we don't have to bring them into the hospital. We could do the first treatment in the emergency room, but only if we have a case manager for afterwards, for the next day to set up the second and third or even fourth and fifth dosing. Some people, obviously, we don't want to infuse at home based on their medical condition or on their insurance issues. We're going to finish with the third of the MS tiers with how we treat symptoms. And I see myself as a quality of life doctor. That's why I love being an MS doctor. While we make those immunologic decisions, we can really affect people's quality of life, but only if we have your help. So actually, for this presentation, I came up with this idea of not just visible and invisible symptoms, but also private symptoms. So as an example, walking is something people can see if you have a problem, or if you're in a wheelchair. Fatigue is invisible on the most part. People say, well, what do you mean? You look so good. That's what our patients are told. What do you mean you have MS? I have a patient who was told, oh, you have MS? My house is a mess too. Other people are told, oh, you're a Jerry's kid. And actually afterwards I'll share with some of you the story I did on ABC News about Jack Osborne being diagnosed. And one of the topics there is that he's going to have counseling, and they asked, what do you think about that? I said, that's great, but most people don't have that luxury. And if the Osbornes can become the public face of counseling for people with chronic illness, that would be an amazing thing for them to do, besides the music of Ozzy Osbourne, which is great. But then there are private issues that are not invisible to your partner, but they're invisible to other people. So sexual dysfunction, problems with sleep, these are things that happen inside the home. Symptoms in MS can come from anywhere inside the central nervous system. We need not just treatments with medications, communication, education. We need to work with our PTs, OTs, speech therapists. It really becomes a multidisciplinary team. Even if we look at gait dysfunction, walking dysfunction in MS, it could be a balance problem. It could be problems with feeling where you are in space with sensation. It could be weakness. It could be muscle tightness. It could simply be problems with vision. So we have to think about the quality of life issues that face our patients. Side effects from medications, headaches. My other subspecialty besides MS, I'm board certified in headache, and actually the connection between headache and MS is a personal interest of mine, as well as, and we can talk about this another time, sports concussion and the legislation that passed in Florida. So disease-modifying agents, sometimes they cause more side effects than people think good. Neurofunctional enhancers, and I'll get to exactly what that is. Quality of life can be increased by our physical and occupational therapists. Sometimes we need walking assistance for our patients. And I find people come with a cane in the wrong hand or the wrong height, or they can't get those electrical stimulators like walking and Lam SL300, and that can really help them get back out into the community. A neurofunctional enhancer is a term I came up with. If you think about it, disease-modifying drugs do not appear in the label for FDA-approved medications. It says to reduce relapses and exacerbation. So somebody in marketing somewhere came up with that idea. So to me, a neurofunctional enhancer is a treatment that enhances the functioning of people with neurological diagnoses. But we can't predict who will respond to a disease-modifying agent, but we know very quickly whether you respond to one of these neurofunctional enhancers. That is empowering. Originally, I called them neurofunctional empowerers, but no one can pronounce that. Then I wanted to call it neurofunctional enablers, but in the United States, the word enabling has a bad connotation. And actually, I tested it on Facebook with patients throughout the country and internationally, and we came up with neurofunctional enhancers. So, for instance, the first one that came out was dalfampridine. Dalfampridine does not modify MS, but it helps the nerves work closer to normal. The electricity that jumps goes closer to normal. And I realize there's a lot of nurses here, and that conduction is called saltatory conduction. Anybody in the room know why it's called saltatory? So I didn't know, but it doesn't involve sodium and potassium and salts. I was watching Dora the Explorer, and she said, Diego, salta, salta. So salta is jump. So because electricity jumps. And this medication can help people not just walk faster like a lot of insurance companies look for, but it can also help their quality of life and help them walk better in the community. MSWS is the MS walking scale, but I call it the MS scale for significance because it means that people can walk better in the community. Sometimes insurers and payers say to us, well, if you don't get 20% better each time, they're going to stop it. That's like saying if your hypertensive drug doesn't get you 20% better each time, we're going to stop it. That it becomes ridiculous, and even when you look through the clinical trials, that doesn't make sense. This is very simple. When there's medicines that work quickly, you ask the patient, are you better or are you the same or are you worse? If you're better on the medicine, you're going to stay on it. If you're not better on it, you're going to get off of it anyway. So to have all of these kinds of hoops that people have to jump through does not make sense. But then the next neurofunctional enhancer went beyond it. It went to something called pseudo-bulbar affect, so involuntary laughing or crying. And what's important here is that it works fast. The fact that the medicine beat the placebo is interesting but uninteresting here. What's interesting is that mean weekly episode. That x-axis is about weeks. It changed from baseline to week 1, even when it was still once a day, not twice a day yet. We know that our patients can look at the second month of being on a medication and say whether it helps them or whether it doesn't. So are we going to see more of these neurofunctional enhancers? We're seeing medications specifically for MS pain. The Duloxetine Cymbalta did a trial which was positive for MS pain. The same medication, Nudexa, is being tested in other doses of dextromethorphan and quinidine, and we're doing a trial called PRIME looking at pain. The antispasticity agents, some of you may know that baclofen has to be given, Lioresal has to be given 4 times a day or 3 times a day, but it has to be given frequently. There are other ways of getting it with intrathecal baclofen pumps, and then there are the idea that you would take the prodrug, our baclofen, and be able to give it once a day. Deep brain stimulation. We do deep brain stimulation in an NIH trial for people with severe Holmes tremor of MS, so severe tremor, and they can deep brain stimulate them, and they can go back to functioning. I have a patient who's an attorney who had to quit because she could no longer shake hands, and she actually had to keep her hand in her pocket because it was so embarrassing. Now she can move around well. So what approach do we take? We take this MS team approach rule, this MSTAR, and we talked about fatigue and the disabling nature of fatigue. I was once talking about MSTAR, and a doctor who's also lecturing who has multiple sclerosis, he said, when I looked at that, I thought it said MS-TAR, because that's how it feels when I have fatigue. I feel like I'm stuck in tar, just like that person who felt like they were stuck in lead. There are the medical side, there's the case manager, the MS nurse, the doctor, all of us working together. We are the background. The foreground should be the friends and community, and in the South, community, the religious community, the significant other, we have to think about the rates of divorce as well, family, the job, the American with Disabilities Act, as well as when you need to apply for disability, and then this rich MS community, and a lot of it is online. We even have support groups in Second Life, which is like this avatar world where we've gone ahead as well. But the important responsibility, one of the issues with accountable care organization is that everyone's accountable except for the patient. The patient is the center of this team. And the way we work is with patient care, educational research, but also what can the MS patient give back to the community at large? Not just to the MS community, but when you give of yourself, you can feel much better about receiving. So people who only receive never feel as good as people in a partnership. And it's one of the problems I see with MS couples, is that the person with MS thinks that they have a caregiver. They don't have a caregiver, they have a care partner. And when you give out to the community, we can form something that's called the MS Patient Network. And the basic idea here is that I have MS patients that used to be CEOs or still are CEOs of major corporations. They should not be licking envelopes for a nonprofit. They should be doing things like financial advising for other patients. There are things people can do that can empower them. I said the good news is we went from pre-1993 no medications, now we have an explosion. And when you open up our journal in neurology, 75% of it is about MS nowadays. And we as neurologists are the most creative people in the world. You know what we call our journal? Neurology. And then we say, well, it's green, so you know what else we call it? The Green Journal. So really what we have seen is this explosion, and it's an exciting time to really be taking care of MS. What I'd like to do now is transition and see how much we get through with some 2 case scenarios. So in the first case, a person comes in with urethral pain. She went to 2 neurologists and 5 urogynecologists who told her that she had between urogynecological problems, and she was told interstitial cystitis. She was told lots of different kinds of issues. Her history is a 41-year-old right-handed. We like to talk about handedness in neurology because if you're weak on one side, it helps us. A white woman with relapsing-remitting MS. She actually was in the middle of a mono infection, an EBV infection, and she saw like a screen through her eye when she was 10. 5% of people with MS are under the age of 18. Probably more of them, like her, had their first symptom then, but wasn't diagnosed until later. 13 years ago, she came out of a hot bath, and she couldn't feel from her waist down. In the 1950s, the test for MS used to be to dunk an MS patient into a hot water, into a hot bath, and see if their symptoms came out. And that's because that conduction, that saltatory conduction, gets blunted when somebody's in heat. So the threshold, the nerves just don't work as well. That's called Utah's phenomenon. And then her MS diagnosis was only diagnosed 6 years ago. So when she was 35 years old, and she probably had her first symptom at age 10. So really, she had it for 25 years without really having any of that kind of diagnosis. Trigeminal neuralgia, the shooting pains, and she was started on daily glatiramer acetate or Copaxone. So a month and a half ago, she had onset of severe urethral pain. 3 weeks prior to that, 3 weeks prior to her visit, she had left trigeminal neuralgia, and in the past, 2 weeks of left eyelid twitching precedes the trigeminal neuralgia. So she's used to these symptoms, but not the urethral pain. She has nothing else besides MS, and there's no other MS in the family, but her mother apparently had steroid-induced mania, and this concerns the patient. Social history, she did not have that early tobacco use, and early tobacco use is associated with earlier diagnosis with MS as well as MS progression. Also, when you're doing injectables and you have that nicotine on your hands, you can never clean it properly and people have more skin reactions. On examination, she was overall normal except she was slightly overweight. Her cognition was fine. She had some right optic nerve pallor, which tells us that she had in the past problems, and that red color desaturation where red looks a little gray. She had no spasticity and she was strong. In terms of sensation, sensation is very useful. She did have a thoracic spinal level, meaning it felt one way, and then when you check lower down, she just felt that it was less of a sensation. And she had some reduction in vibration and proprioception. Her reflexes were mostly normal, but she had some hyperreflexia. And she had upgoing toes as well. Normal coordination, and she had a slightly wide-based gait. We have to prioritize her issues. Here, I think it's important. It's no question to me that her severe urethral pain is her most important current issue. What are the safety issues? So her walking, she has some wide-based gait. We wonder whether she's walking okay or what needs to be done with that. If she has some sort of involvement in her spinal cord, that could be important for safety issues. And our next steps. So the next step for this patient is MRI. MRIs are expensive, but they're not that expensive. They are actually an extension of our neurological examination. I knew exactly where to scan her based on the examination. I knew from the history and from that exam that she had a thoracic spinal cord lesion as part of her MS. And I needed to do an MRI to verify that and to be able to tell those 2 neurologists and 5 urogynecologists that they are wrong. MRIs, open MRIs, mean a lower Tesla, lower magnet strength, so they're not as good. So this is a form of imaging. This is MRI. This is looking sagittally from the side. And this, we call this T2. And in this T2 lesion, about halfway, you can see that there's some white area. And with that arrow, you can see what we're talking about. Then we give the gadolinium, the dye. This is why the dye is so important. It shows the dye uptake, which means she is having an active MS relapse that involves her spinal cord. And this is where a good history and physical exam helps you. Because I could say that to her immediately, but the MRI was very, very important. So the spine really does matter. And a lot of times we get denied spinal cord MRIs, but they can be very, very useful. So when you scan her brain, there's no new lesions on the brain, but there is in the spinal cord. So we have to think IV solumental, IV methylprednisolone, or are we going to go ahead with IM or subcutaneous ACTH, adrenocorticotropic hormone? For this patient, she was very scared of corticosteroids because of her mother's history. So we actually went with adrenocorticotropic hormone. Now, ACTH is an expensive medication. On the other hand, her being hospitalized for Baker acid with mania would be very expensive, and her refusing treatment would be even more expensive because there is a high risk of disability with spinal cord lesions. Off-label, we could think about IGIV, transfusion immunoglobulin, and plasmapheresis, both with their own costs, both with their own side effects. I've seen a pulmonary embolism from IGIV or IVIG in the past. We have to think, is she on the right medicine? Does subcutaneous glitaracetate is the right thing? We have to think about depression. How much is depression an issue with this patient? What can we do? We have to help with her pain management. She has urethral pain. We don't give her narcotics for that. We have to give medications that are really going to target what's going on. We have to coordinate her care with the urogynecologist. I still need their care. I still need their help in figuring out what to go on. I need their help with bladder management. We have to look when she has urinary tract infections. A lot of times patients with MS will not know that they have it, but the UTIs can cause a lot of disability. Similar to Friday afternoon, anybody works in an emergency department, and Friday evening you see grandma coming in with a stroke again, but all it is a urinary tract infection. The same thing happens with MS patients. There's exercise, there's Kegel exercises, biofeedback, oral treatments, botulinum toxin, so botulinum toxin type A, trademark Botox. Then there's neurostimulators and surgical. So you can take the wrinkles out of the bladder with the Botox, and actually it's FDA approved now for neurogenic bladder to help with that idea. But we have to separate if a person's having too loose a bladder and sphincters, or that it's too tight. Is this like gotta go right now kind of symptom, or is this another symptom that's going on? As we can see here, there could be a normal bladder, a patient with urge or frequency, and a patient with urge incontinence. Exercise really can help. It helps to strengthen the muscles of the pelvic floor, and really we can see that doing that contraction and then relaxing can be helpful. So with your permission, we'll go to a second case that's very brief. We'll talk about a 47-year-old man with a history of relapsing remitting MS. Now with gradual deterioration. So instead of these relapses, he's having this progression. He's going from walking to using 2 canes and sometimes even a wheelchair. He has frequent falls, so major safety issues for hip fractures. And people who are using wheelchairs are more likely to have brittle bones because they're not placing as much weight on their bones. So they're going to have more of a chance of osteopenia and osteoporosis. And all the issues with bisphosphonates at the FDA have become the bane of our existence with our patients as well. He has an ability to maintain erection as well, so he has sexual dysfunction. This is something that if we don't ask the patients, they don't tell us. Most of our patients, 2/3 are women. Most neurologists, 75% of us, are over the age of 45, and most are men. which means that patients don't always volunteer the information, or the doctors don't ask, and both of those are important. So I encourage both patients and doctors to discuss it, but it's also useful when case managers and nurses get involved. They can often help us bridge that gap that sometimes happens. In the past, he's been treated with interferon beta-1b, beta-1a, mitoxantrum, and now he's on glutaramate. So the question is, it's now 2013. So what will we do in 2013 for this patient? Will we treat them with Tysabri, natalizumab, with oral fingolimod? Dimethyl fumarate is also called BT12, which hopefully we'll see 2013, teriflunomide, alemtuzumab, those are the other medications. Or would we do one of those above and a neurofunctional enhancer? Remember, he has a lot of symptoms. How can we help his symptoms, not just modifying his disease? Because perhaps the progression has nothing, there's nothing we can do about it right now because we do not have FDA-approved medications to help with that. On the other hand, we have reasons to believe that some of our medications help with disability progression as well. Management of progressive MS is really one of the most challenging things we can do. There's no proven disease-modifying agents. Novel therapies do not fully address the question of progressive MS. Symptom management becomes key, as well as with neurofunctional enhancers and with rehabilitation interventions. Thank you so much for your attention.
Thank you very much. There's a presumption that we're referencing patients that have payer sources. Do the medications that are listed, do they all have indigent programs for those patients that are not going to qualify for any type of financial services?
Yeah, so one of the biggest problems in American healthcare right now is not the indigent patient. It's the patient who's Saltatory, has a small business, never bought healthcare insurance. So all the programs have, and there are varying qualities. We fought hard. Most of the medicines now have zero copay for everyone. And the problem becomes there are people who fall between the cracks. The indigent don't fall between the cracks. It's the people that make enough but just didn't buy insurance, and that's where we have some of the issues.
See, what my challenge is I'm from Arizona, so all my patients between the ages of 18 and 65 that don't have dependents don't get insurance. No insurance, nothing. So what I'm looking for right now, what my bridge is for these patients is hospice. Because, for example, Tysabri is around $6,000 or $7,000 a month. We have no financial resource to manage these patients. So the challenge that I'm running into is the fact that there is nothing for these types of patients. So they have no type of medication assistance whatsoever.
Well, so the individual companies have, like I say, varying quality. Then there is NORD, but NORD's the North American Rare Diseases. So that's running out of money as well. A lot of the companies pump money back into NORD with the expectation that their drug is the one going to be able to be chosen. But you brought up an example. You brought up natalizumab. Natalizumab or Tysabri is intravenous. So there's actually two costs. There's the cost of the medication, but then there's the cost of the infusion, which is not always negligible. So sometimes it's difficult for me to be able to tell a patient how much something's going to cost. If it was just a medicine, I could call their insurance and say, what's their cost going to be? When I call for that, they tell me, well, their co-insurance is going to be $100, but for the infusion, and what the infusion place is going to charge. So it becomes very difficult, and that's where physicians rely so much on case managers, so we're not the ones also calling. We tend to be also, but not the ones also calling, trying to not only figure out what the right medicine is, but figure out how a person's going to get it. Now, engaging with the nonprofits that know more about that, unfortunately, so many of them just refer the patients back out to those patient assistance programs in the companies. So the way I see it is the people who can put the most pressure on the companies to start doing better are actually physicians. We as a physician community have to get better at explaining to these companies, if you want us to prescribe your high-priced drugs, you need to give the drug for free or for cheaper for patients in need. We try, but it's not always successful.
speaking from the viewpoint of the Case Management Society, one of the things that we're really looking at are what are the tools case managers need to be more successful. And if one of the tools you need is better information about patient assistance programs, then I ask you to tell us, and we will develop a focus on closer relationships with the different organizations. There's a number of programs for the aging. Now, we're talking about a disease state that may not touch the aging. So you give us the direction of what you need, and we will work as hard as we possibly can to get that information to you. So I will take this question back to our board and see if we can develop further information. Sitting next to you is the chair of our education committee, and I couldn't think of a better project for Laura to put under her belt. We have a question over here.
Just a follow-up. There's a really great website called needymeds.org that lists all the patient assistance programs in the country. And
if you use the mic, then it goes on the recording.
there's a great website called needymeds.org, and it lists all the patient assistance programs in the country. And every time I've needed to look for a med, I found it available through the pharmaceutical companies, except for the very brand new meds. Needymeds.org.
NEDYMEDS.org.
And it's a very easy website to navigate. They list the meds separate by generic meds and brand name meds. And it's a fantastic resource. And you can print out the application for that pharmaceutical company right from the Needymeds website. So it's a fantastic service.
One more question, please.
A question about culture, I guess, and about the immigrants that are coming into the country. Caucasian is still the highest. Is that changing? Do we see a trend that is changing any? Because we do have a high immigration rate in the United States.
So actually, the Kaiser group, they looked at their data, and actually the greatest increase was in African Americans, not Caucasian Americans. So in Africa itself, there are some cases of MS. It's underdiagnosed for a variety of reasons, but it also probably does have a lower baseline prevalence. But what we are seeing in America, we see that some of us think that Caucasians and African Americans, it's about the same. Hispanic Americans, it is somewhat different, but in Puerto Rico, 50 per 100,000 people have multiple sclerosis. So it's not 150 like in Scandinavia, but it's not 5 per 100,000. So a lot of it does have to do also with the environmental exposures, and of course also with the genetics. Some of us say everywhere the Vikings went is where there's multiple sclerosis.
We have one question up front. Wait, Judy, hang on until she brings the mic.
You mentioned about IVIG in the acute exacerbation period. Do you know if that is covered in the LCDs, the local coverage determinations for Medicare? And if so, what kind of criteria they're talking about?
Yeah, so the local coverage determinations for Medicare, it's different in every MAC, and the MACs are changing. But as far as I'm aware, there's probably little to none that actually cover it in terms of that. And that might be fair. It might be. Our data, even for IVIG as a disease-modifying agent, is split. Half the trials are positive, half are negative. It depends on what the placebo is. And actually, when the placebo is dextrose, it's a positive trial. But when the placebo is albumin, it's negative. And that raises the question to me is whether albumin may be a really cheap alternative treatment for multiple sclerosis. But no one's going to do that trial because no one's going to pay for it.
Thank you.
Do we have any other questions? Then thank you so very much for your time and your attention. Oh, we have one more question.
I just wondered, is there any problems with stem cell research?
Yeah, so, you know, back in the 90s was the time of genetic engineering. We were going to solve every disease with genetic engineering. How many diseases have been solved by that? Stem cell research, while there are trials going on, most of the trials, the people all get chemo, and everybody gets better from the chemo. Not every, you know, it comes down, and then the stem cell does a little bit better. My question is, a stem cell is a cell that can turn into any part of the body. If you put it in the bloodstream, how do we know it's not going to turn into a blood vessel? Or it's going to turn into a liver, or it's going to turn, that's the whole idea, it's a stem cell. So I think the first real application we're going to see is people with high spinal cord lesions. So where they're going to be paralyzed. So the risk of the surgery is low compared to where they already are. And if you put a grid on top and put stem cells, you're actually doing a local application. But I'm still not sure how putting it into someone's vein, it's going to not become, you know, it's not going to become a heart cell, or like why is it going to become a nerve cell? The whole idea is that it's a stem cell.
Again, thank you so much for your time.